Welcome, everyone. I'd like to turn it over to Dr. Cheryl Maurana from the Medical College of Wisconsin. Dr. Maurana.
Good afternoon, everyone. I'm Dr. Cheryl Maurana, and I have the privilege of serving as the founding director of the Kern National Network for Caring and Character in Medicine, or the KNN. We're grateful to have all of you join us for the third session in our discussion series, The Medical Profession Through the Lens of Human Flourishing. Next slide, please. For those who are new to the series, we would like to briefly touch on the work of the KNN. The network believes that when learning environments, practice settings, and healthcare organizations support the well-being and purpose of healthcare professionals, then clinicians, patients, and families can truly thrive, not just survive. That is our aspirational goal at the KNN. By advancing caring and character in medicine, we aim to ignite change that helps individuals, communities, and society to flourish. Next slide, please. The framework for this work both compels and guides us toward flourishing for all, requiring each of us to consider what is needed for various individuals and groups to flourish by their own measure. We know that this year there has been heightened attention to ongoing disparities, including those within healthcare. We also know that we need to have more and diverse voices discuss differences in perspectives through authentic conversations. Today, we aim to inspire consideration and action about ways to address equity in the context of character, caring, and flourishing. We also aim to create a space where people can relate across differences. In preparation for this session, 3 healthcare leaders have graciously shared time and insights with us, and each meeting with them has truly been inspiring. We hope you will find the same from our discussion today. Next slide, please. We are joined by Dr. Joe Greer, Professor and Dean of the College of Medicine at Roseman University of Health Sciences, Dr. John Lowe, the Joseph Blades Centennial Memorial Professor at UT Austin School of Nursing, and Dr. Carla Pugh, Professor of Surgery at Stanford University School of Medicine. Dr. Chris Stawski of the Kern Family Foundation will facilitate the session. Next slide, please. Before we begin, there are 2 quick notes. For best viewing, please select Speaker View as shown here. To submit questions for our panelists, please send a chat directly to Q&A. While this will help us keep things running smoothly, let us also extend grace to each other as we join from various places and spaces. As we begin this afternoon, Dr. Lowe would like to lead us in a consideration of the locations we inhabit, and to pause and to reflect on and respect the history and tradition of those lands. Dr. Lowe?
Thank you, Cheryl, for the honor and the opportunity to be here today and to introduce this practice and tradition. This practice and tradition has its origins in Australia as one of the places where it originated when Prime Minister Rudd in 2008 delivered the Great Apology to Aboriginal people of that land. In one of the ways that Prime Minister Rudd wanted to bring awareness to that country and nation that there were indigenous people there and their origins. So what was mandated was that any public forum, there would be an acknowledgement of the people and the original lands that they inhabited. So this has become popular throughout the world in many areas, and indeed in the United States, although it has not become as a mandate via policy, but many institutions have adopted it as a way to acknowledge the original peoples, which would be Native Americans and other indigenous peoples of this land. So we do this by taking a few minutes just to reflect on who those people groups were. Some of those tribes are still here, and some of the indigenous people are not, but those origins. And what I would encourage you to do is at some point in time, if you would look and discover who were the original peoples. And it gives an awareness, and also demonstrates and conveys the respect that if it were not for the sacrifice of the ancestors of the people who were here, we would not be in the places that we are, in our buildings, our institutions, our homes, etc. So if we'll just take a couple seconds just to reflect for a minute, and just a moment, and then Cheryl will pick it back up. Well done, thank you.
Thank you, John.
Well done.
Thank you again, John. We really appreciate you doing that for us. Now we will turn things over to our moderator, Dr. Chris Stawski, to begin the panel discussion. Chris?
Thank you, Dr. Maurana, and thank you for Dr. Lowe for leading us through that acknowledgement. We are honored to have several wonderful panelists with us. We'll start by giving each an opportunity to provide background and briefly tell their story, then open into a moderated panel discussion. Afterward, we'll gather audience takeaways and ideas for how to advance progress toward inclusion, belonging, and equity before heading into an open Q&A session to take your questions. In telling their story, we have asked each of the panelists to consider the following 4 questions in shaping their narrative. First, who are you? Second, what hurts the most? Third, why have you flourished despite the current affairs? And fourth, what can we all do to make sure others flourish? To start us off, please join me in welcoming Dr. Carla Pugh.
Thank you for allowing me to share my story and answer to these questions, and also to be on this panel. When I think about who am I, that's a really big question, and I narrowed it down to, in the context of this meeting, in the context of human flourishing and the medical profession, I am a surgeon. I'm a surgeon at the core. I love human anatomy. I love the challenge that the human body presents when it's affected by a disease process. And I have the ability to collaborate with my family, with families, patient families, as well as my colleagues and other specialties to take care of patients who have a disease process that's amenable to the surgical approach. Having said that, I realize that I'm saying that to you, and I am a Black female. And to put that in context, I am very aware that most people view a surgeon as a white male. And in essence, I am also a statistic. And I've learned more about what that means to be a statistic in 2017. I found out that I was one of 10. And this comes from the AAMC database on faculty in academic medicine, that I was one of 10 Black female professors of surgery. And that's not something that I'm proud of. That's actually painful to know that. And I would submit right away, it's not a pipeline problem. I came to my medical training with a fair number of Black and brown females who wanted to be surgeons, who are surgeons. And so when I learned that, first it was difficult to accept and to believe. Then the 2020 data came out and says that there's 15 of us now. Wow, we made some progress. This is beyond believable. It doesn't make sense that there's 15 Black female professors of surgery in all of the United States. It does not make sense. So I'm beyond passionate to figure out what I can do to help those who dare to dream to be a professor of surgery, professor of anything. I mean, it's just unfathomable, and the numbers just don't fit well with me. I think the last way that I characterize myself is I am a new, up and coming and learning upstander. And I think that when you combine being a statistic and with how I am embodied or viewed, you know, by the medical profession as a Black female surgeon, I think it's imperative, as someone who made it, you know, of all those who came through the pipeline from medical school, and, you know, and yes, I'm a professor at NIH funding, and I am living the dream. But I think it would be a huge disservice to those who are coming behind me if I don't share and tell the stories of what I experienced along the way and what I continue to experience on a daily basis. I was racially profiled in the ICU 2 to 3 months ago. It happens on a regular basis. And these are things that there was never a platform to share and to talk about those events. But if I don't talk about it, then I allow my colleagues to believe that I made it because it either doesn't happen to me or because I have some magical resilience. Well, guess what? I don't. And it does happen to me, and it happens regularly. And I do get upset. I do get angry. And I bring it home to my family. In the last event, now that there is a public forum to talk about this, I actually partnered with the white female nurse, who, by the way, is an amazing human being, who was completely unaware that she was capable of delivering a micro-exclusion. And we reenacted the event, and we are now partnering together to share with others that we realize that this is pattern recognition and natural human behavior. And intent is one thing, and she says it was never my intent, and she is shocked that just in that moment, her unconscious bias came out so quickly. And she asked me, did I belong? Fully dressed in my uniform with Stanford all over it. And I did my appropriate microaggression thing and said, I'm sorry, I didn't hear you. And she repeated it again. We reenacted it, and we are now using that as an education piece. I'll be quick. What hurts the most? I think what hurts the most is that race has been publicly politicized, and we have not made progress on the conversation, how to educate ourselves. And I think that that is what hurts the most. And I think the irony, we are healthcare professionals. My goodness, we have the ability to address this. We just need to come together and lead the way. We have the ability to do this. I 100% believe it, and I know it to be true. Why have I flourished? Wow. I think the one thing that I come back to is that I grew up in a diverse community. Berkeley, California. My mom's best friend was a white Irish woman with red hair and freckles. I did not know that she was white until I was in high school, and people said, oh, why do you have a white woman sit on your couch? We never talked about race in my house. I did not know. And the positive effect of that is that I feel I am entitled to have a diverse group of friends, a diverse group of mentors, and I don't have a sense of fear and distrust based on appearances. That's how I flourished, because I feel entitled to have a diverse group of friends and supporters. When I think about how do we help others flourish, I have two things. It's hard to choose, there's a lot, but I think that we are at extremely high risk of creating the same mistakes with people of color that we made with women when they entered the workplace in the medical profession. You hear the comments now, the same thing that women face. Why aren't there more women professors? Oh, it's a pipeline problem. We've been saying that for 40 years. Now that there are more numbers of female medical students applying and entering medical school than men, we see that it's not a pipeline problem. It's a problem with a culture of inclusion and belonging. But we're now saying the same thing about Blacks and brown people of color. Oh, it's a pipeline problem. It is not. Black and brown residents in specialties who have made their USMLE scores past the interviews are being fired. Not choosing a different profession, different specialty, they are being fired at 4 to 6 times the rate of their white counterparts. It's not a pipeline problem. The other thing, lastly, is that there's now we now have data regarding the microaggressions, and everyone's like, well, I try to do my best, I try to be inclusive. Guess what? In 2 completely different studies, it turns out it's the patients that deliver the majority of microaggressions. The patients. We have work to do. We have to find out how to protect the patients while they're ill, but we also have a responsibility and a duty to create a work environment that is not hostile. We can do this. You just have to pay attention to history and look at the data. Thank you.
Thank you, Dr. Pugh, for those moving comments and for your reflections on types of actions that you think could be done. With that, I would like to transition to Dr. John Lowe. Dr. Lowe, take it away.
Great. Thank you. Thank you, Dr. Pugh, also for your words, and very meaningful. So I will just introduce myself a little bit in my tribal language. I would say Osio Teija, Kadoea, Johnny, Wadon. And so I guess, share with you who I am known better as. I am known probably best by my students and colleagues within this country and around the world as the indigenous male version of J. Lowe. So please feel free to refer to me as that, and it always gets my attention. So it's always a fun thing to feel like you're a celebrity. So without having some of the talents the other one has. So thank you again for the honor of being able to share who I am. And so my story really begins in my ancestry as a Cherokee tribal member. My father was Cherokee from his mother's side, who was a full-blood 100% Cherokee, and his father was 100% Creek, which is another tribe. And my mother was Lenape tribe, and she passed away when I was young. So my paternal grandmother really served as our maternal figure when we were children and growing up. And so so I like to think about when probably my vision started for research. And I think back at when I was about 10 years old, and we had a real favored cousin returned from the Vietnam War. And I say favored because he was fun. He was fun to be around, and was really good at sports. And so we just really enjoyed him. But when he returned, he seemed lost, and there was trauma there, and he turned to alcohol to cope. And so at the age of 32, he succumbed to the complications from alcohol abuse. And I remember my grandmother, who spoke very little English, when he passed, and she said, "It got another one of us." And I recalled thinking, because I was very close to my grandmother, she taught us a lot about our culture. Our culture taught us a lot about our traditions, about herbal medicines. And I saw the grief, and it was related to this it. And I remember thinking, if I could do something about the it, then I could help maybe to relieve that grief and that pain and suffering. And so here I find myself today, many moons later, and this is exactly the work that I'm doing. And so there is the question, how did I get here? I'm going to now share another story within the story. And so I am one of 25 Native American nurses who have a doctorate degree in the US. And when I finished my doctorate, I began as a faculty member at a university in South Florida. And it was November, it was the month of November in one of the early years. And I was asked to give a presentation to another university that I was not affiliated with, to their health science center, because it was Native American Heritage Month and they wanted a presentation about Native Americans. And so I, gathered my information, the information I usually share with students and around who Native people are. And there were in the auditorium was pretty full. There were students from every discipline. They had a med school, they had a nursing school. They had other health disciplines, schools there represented, along with faculty. So of course I shared the information that I usually share, is that we survived and that I consider myself a survivor of the genocide. We went through a genocide experience in many ways. We still are going through that experience. And shared my story, what it was like to grow up in a family, in a community where there was poverty, where we had relatives who had to go to a boarding school. My siblings, we were fortunate that when the vehicle would come through the neighborhood to pick up children to take them away to these boarding and residential schools, my grandmother would say, run to the back door, into the storm cellar, and hide because you might be taken away. We know the stories of our auntie who went to a boarding school and how brutal and abusive that was. And we were now discovering, in Canada, the most recent events around discovering the mass graves there. And we're discovering, and more in the US too, that some of the same experiences happen in the US. So plus, I would share the dispossession, what that meant, historical trauma, generations, intergenerational trauma, how it would be transferred and transmitted generationally, why we have the high rates of diabetes, some of the highest rates of alcohol abuse, and on and so forth. At the end of that presentation, a young gentleman, Caucasian, stood, and must have been a student because of the age, stood and it was Q&A time, and stood and said to me, I just this just doesn't, I just don't get it, and said, you people are always looking for an excuse. And so I remember thinking, wow, I just shared with you all this pain and suffering and wanted you to become aware, and etc. So I've been very fortunate throughout my life, and especially my career, to have a group of elders in my tribe that have helped me through and have stayed connected to me, and are now advising me that I'm heading into elderhood myself. So Lowe is eventually will become an elder. And but in some of those earlier years, they really didn't want to lose me into what we call the academic world, those institutions, and they really kept their eye and kept in touch with me. So I had an opportunity to visit with them after that incident. And I shared, like, where did I go wrong and why wouldn't somebody in the audience understand and get it, what I was trying to explain, why we have the issues we do among our people. One elder said to me, where there is understanding, there is no need for an explanation. Where there is no understanding, there is no explanation. And asked me to think about that for a while. So it really caused me to really think about that and shifted me. And the other thing they really helped me to really become and begin to think about was what was my purpose? Why was I created? What's my purpose? And have I connected to my purpose? And so that shifted me into really developing the intervention that's now evidence-based, that there are federal agencies like the US Department of Justice has evaluated and examined the evidence with the intervention, that it is an evidence-based intervention. It's called the Talking Circle. We really began to help our youth understand who they were and who they are. And this intervention now is in other countries, that they were created to be a sacred being because they were created by a sacred being. And in that are all the values and all the gifts and talents that they have to contribute to what we call the human family, society, to the world. And so they do have purpose. And so it's been very rewarding to have this opportunity to do this work, and to have been funded multiple times by NIH to study and do the randomized trials and continue to do that. And have the passion. So connecting to your purpose, and the passion is the energy that comes when you're really connected and that's your purpose. And then the vision, what we call the visions, and that's when the doors and the pathways open up for you to be able to carry out your purpose. And so have had so many opportunities and so grateful. The other piece of that story is now what that my elders really helped me to really think about in that situation when I was presenting. What was I looking for? What was I looking for? Was I looking for vindication of all the victimization, of all the genocide, of all the trauma? What was I looking for? An acknowledgement from the group to say, yes, okay, yeah, we know this happened. We're sorry it happened. Some would say, well, that wasn't me, that was somebody else, that was not my generation, I didn't have anything to do with it, et cetera, et cetera. And really, does that heal? Would that be healing to me if that had happened? If I got that acknowledgement, and sometimes I would, in some presentations, folks would say, we're so sorry that happened. I'm sorry my ancestors 3-4 generations ago, dispossessed your people, etc. So I shifted in thinking, helping in my role as an educator, as a health scientist, helping those that I intersected with, that I interacted with, how would I approach this in a different way? And so I began to work with others, even in presentations in a huge conference. If I was the keynote, I will usually ask, please have everybody sit in a circle, because we view life circular. And it's interesting when you think about how our education system is set up. Where do we have students sit? In rows. Who do they have to look at? Well, if they look to the left, they might see somebody. If they look to the right, but they have to choose to do that. And then if you're in a circle, you look across and you are facing others. And so one of the ways that I began to, and still do, work with others is to have others look at, they have a purpose also. And is that purpose to dispossess someone of their purpose for being? And is it to create inequity in others by dispossessing them of their ability to live out their purpose? And if you're sitting in a circle and you look across and you pull one person out, or you diminish a person from living out their purpose, what happens to that circle? It's dysfunctional. The human family becomes so dysfunctional. And I think we can say that's where we're finding ourselves. We have come to a place where the human family has become somewhat dysfunctional because of the inequities, because there has somehow been this thought that my purpose, I could diminish someone else to become my purpose, so that my purpose was better. And so in looking at that circle, when you look at each other, when folks are in a circle and they look at each other, they're at the same distance from each other. And we like to think about the center of the circle, that space is our creative force, whatever you want to call that. And so each person in the circle is at the same distance from that creative force. So no one was created to be less than or greater than anyone else. And that we all have a purpose and we all have the right to live out that purpose and not diminish another's. So that's sort of where I have evolved and with this, and that's my story within a story. And I appreciate that. And I think I'll stop with that. Well done. Thank you.
Thank you, Dr. Lowe. Thank you for sharing your story about yourself, connecting with purpose, vision, and ways in which to socially connect with each other through this idea of circles. So thank you. With that, I'd like to pass it to Dr. Joe Greer. Dr. Greer, take it away.
Thank you. I guess you put the old guy after these two great individuals. I got to tell you, the stories are fantastic. I'm Pedro Jose Greer. I'm Cuban Irish of all backgrounds, so I'll classify my ethnicity as Cubish. And I grew up in this country in the early 60s and 70s, early 70s, going to college at the time of great strife and in the South. And that's why I go by Joe Greer, because it's really hard to find a redneck that can pronounce Pedro without having Vanna White give him vowels. And when I went to college, I actually went to play football at the University of Florida. It was the third year they had desegregated the Southeastern Conference. So the South was very, very different than Carla, where you grew up, and John, we didn't have the suffering and history that you did, but there was enough of it going around in this country that wasn't really good. I'm by formal training a gastroenterologist and hepatologist, and went into hepatology because when I was in training, I found that Cubans had twice the incidence of hepatocellular carcinoma as the rest of Americans. And it turned out to be hepatitis C. And it was a social determinant. Upper middle class families had syringes and needles because in our culture, vitamin B12 is something you got to give all the time and make sure you have all your vaccines. But they didn't clean the needles well enough to get rid of C, which was back then non-A, non-B. I remember the first time somebody called me a spick, which is a term that originated during the building of the Panama Canal Zone. And basically because we would say things like, I speak it English, I don't speak it English. A lot of people think it comes from Hispanic, but that's a term that really wasn't popular until the 1970s. And I came home. Now, I'm 7, 8 years old on my bike, and I'm thinking, they think we're clean, spick and span. That's the only relationship I had to it. And my mother explained to me that A, no, that's not what they were saying. B, you should feel sorry for them because they need to be educated. But the most important lesson she gave me, which I carried with me, was remember what it's like to be prejudiced against. That way you never, ever make somebody feel that way. Because all three of us here have been lucky enough to be in positions of leadership and becomes important. Now, what hurts me the most? I'm in a profession that's racist, xenophobic, sexist, elitist, which if that's not enough to deal with, we're losing our virtues. Empathy goes down after the 3rd year of medical school. Humility, social accountability, social justice, and things that we should be fighting for, defending our patients. COVID exacerbated what we had already done. Those that we have ignored in our communities, the lower socioeconomic, Black, brown, rural, Native Americans, are the ones that suffered the most. And now as we go through this Delta variant going through there, people wonder, why aren't they getting their vaccines? Well, why would we trust the system? When in the height of the pandemic, we weren't being taken care of. And we were thrown in the front lines, grocery stores, working anywhere, working in nursing homes, et cetera, et cetera. So it bothers me that that's the profession I'm in, and that's something that I fought for my entire life now that I have Medicare, that it's something we should strive so much higher for. Whenever an entering class of medical students come in, I tell them they have 4 years to save the world, and they wasted 1 week in orientation. And the reason I want to set the bar that high is I don't want them to become comfortable reaching the bar. I want them to know that this is a battle that continues, and we should be the true advocates of our patients. I know that the nurses are. We as physicians have to be the true advocates of our patients. We need to change the culture of medicine. We need to change it to where we make a difference. This is the 2nd medical school that we're starting up. We were founding faculty at one that we started up in South Florida, and we were able to prove this elitism within our profession. 70% of the students that got into our school only got into our school. 55% were underrepresented minorities, not 5% for Hispanic or 6% for Black, 55% total, reflecting the South Florida region. Here's the amazing thing behind it. Every single graduating class that we had until last year when we came out here to start this school had the highest steps, 1, 2, and 3, the highest match rate. And we had 45% first generation college. What did that mean? We were giving somebody who had been prejudiced against the opportunity to actually go out and begin earning wealth for their family. When I say wealth, I'm not talking Bill Gates. I'm talking about you own a home. You could pay for your kids' education. It perpetuates. And why am I so passionate about that? Because my father is the first one to finish high school, much less go to college or medical school in my family, and afforded us the opportunity to do this. I am driven by the stories and the narratives that I have from the patients that I come across. When 1984, when I was an intern, we started a homeless clinic and then clinics for undocumented. And I recommend to all medical students, either now on your iPhone, but before, just write it down. When you have these interactions, write them down and remember them. And let me just give you one. It was our homeless clinic. It was a Tuesday night. I walked in, and we used to have it set up so we had a pediatric section with a glass door, and the mothers could relax in another area with daycare in there. And I walked in after I left my clinic. I had a sandwich with me. Obviously, I didn't need the sandwich. I'm a non-purging bulimic, for goodness sakes, but walked in, and there was a mother with 3 of their kids from the Salvation Army. And the youngest kid, about 6 years old, had really sweet eyes, and I handed him my sandwich. And the little boy took that sandwich out of the bag, unwrapped it, cut it in half, took 2 bites, put it back in the bag, and stuck it in his coat pocket. Now here I am. I've done 3 fellowships. I've been through more education than maybe I needed it, but than is necessary. And I couldn't understand what a 6-year-old homeless child was doing. Here he was in a homeless shelter where everybody knew he was homeless. And one of the big mistakes in my life was putting the name homeless there, because you label people. And I asked him, why'd you do that? And his answer has stuck with me to the day. And his answer was, because my brother's hungry too. And I think about that every single day. Who am I to judge somebody beyond a disease or a therapeutic intervention? Am I really thinking about somebody else when that happens? Do I think about what happened to them in the past or anything like that? Or am I so stuck in myself or this profession that it's about us. That, you know, what's that old saying? In business, the customer is always right. In medicine, the doctor's never wrong. We have to change that power differential. We have to become at a point where people feel so comfortable that this is where we want to go. And to change these different aspects, we have to do that from our leadership position. The team that we came out here with, there are 8 of us. Of the 8, 6 are women. 50% of women in this of medicine in this country are women. 10 to 12% are academic leadership, period. And much less if you're African American or Hispanic. There's only 4 Hispanic LCME accredited deans in this country, and 3 are in Puerto Rico. But that doesn't mean that we need more Hispanics. We need more everybody. 4 out of the 8 are African American. I'm Hispanic. 2 are foreign born. One's from Canada, but it's still foreign born, so I'm still including that. But we need to be able to pave the road that's already been paved for us by others who have taken the real sacrifices. We have to be able to produce a physician that understands social justice in the true meaning of the word social justice, not in the politicalization of it. We have a social justice wall here at our medical school where people put up posters and different things that reflect what they have seen. But it also becomes important because we are community dependent, not community engaged. We are dependent on the community to teach our students and to improve their lives. And all I can say is, first of all, thank you, and I'm honored to be with such distinguished faculty members and doctors. Really, Carla and John, you guys are great. And J-Lo, do not wear that orange bikini she had on a yacht, okay? But this is our world to make better. This is something, if we want to leave a legacy, it's not about what we published or what we did, but that we were part of a team that made the world better.
Thank you, Dr. Greer, for sharing your story. It's amazing to hear each of the 3 stories from your respective life experiences here within the United States and given your cultural background and your experiences in medicine. So thank you. For right now, given time, what we're going to do is transition to the next portion of our program before we do the audience Q&A. And before we do that, let's pause to reflect on key takeaways from what we've heard so far. So, Jean, can you share the link in the chat? On the chat window, Jean is sharing a link that we'll be using to gather responses. Please click that link to go to Poll Everywhere Online. There, you'll be able to enter words or phrases to populate a group word cloud. If you prefer, you can even participate by text message. Just send KNN discussion to 37607 to join, then begin texting in your responses. We're asking you to share 2 to 3 keywords or main points that struck you from the discussion so far. If you'd like to enter a phrase, please put a tilde between the words instead of a space to keep them together in the word cloud. You can typically find the tilde next to the number 1 on your keyboard. You may need to hold Shift to access it. I can see we're starting to get several responses. See, community, dependent, everything in context, respect. Each of these themes have come up emergently across the 3 talks. Dedication, empathy, humility, advocacy, mindfulness, change, support network, representation, social justice, purpose, dignity. With that, thank you once more for sharing what resonated you from the panel discussion. While we take the audience Q&A, we also be inviting everyone to consider how you might integrate those key lessons into your daily life. We're launching an open-ended question to ask, what is one thing you plan to do to advance progress toward inclusion, belonging, and equity. Once again, please follow the link Jean will send in chat to share your thoughts. Your responses will be anonymized. For this activity, there is no need to use a tilde between words. Simply type in your thoughts and submit. You can also participate via text by sending KNN discussion to 37607 to join. We will leave this question open during the Q&A session and return at the end to view responses. So with that, let's transition to the Q&A for everybody. And here's a question about kind of the broad aspect in terms of how do you suggest we get the dominant group engaged in health equity when the majority do not see a problem? You can see from each of your experiences coming from Hispanic, African-American, and Native American backgrounds, what do you think about this particular issue when the majority doesn't see it as a problem?
We have to, in my opinion, make it one of the aspects for admissions. Relook at pre-med requirements and see what really isn't necessary. Is it better to take liberal arts and understand the world, or organic chemistry that you're not going to use? I mean, these are things we need to question. The other one is faculty development. Do not bring in faculty that does not have the same virtues and things that you do. This has to be ingrained in our profession so that those that sit outside of it are the ones that feel uncomfortable for not having those virtues. That's the way I see it. Listen, I'm an old 60. I'm one of 4 Cuban Democrats from my generation. I used to be a hippie. And so it's sort of like, be a disruptor, make it happen.
Dr. Lowe, Dr. Pugh, would you like to share a response?
Yeah, no, I agree with Joe, Dr. Greer.
Joe,
I definitely agree. I think it's interesting just that anecdotally, I could say we because it's my department, a Department of Surgery at Stanford. We didn't believe that we had a problem either. I started asking, individual faculty, how the residents of the first Black female professor of surgery with tenure in Stanford School of Medicine. When I arrived, there were some incidents that were happening on campus, and I had the residents of color to my house, and we talked. At the same time, I discussed with some faculty who are friends and colleagues of mine. I'm like, yeah, no, we're doing well. We don't have, those issues. And in a month of creating a platform where the residents could share their experiences, people were blown away by what the residents were experiencing in the hospital. They had absolutely no idea. And so it's one thing to watch TV and say, yeah, that doesn't happen here. It's another thing to create a platform to really check in and create a safe space for people who are passing through. Most of the residents, they're like, I'm here for 5 years. I am not going to be labeled someone who's a complainer, so I'm not going to openly share. You actually have to create a platform to hear what's really happening in your own backyard. Otherwise, people will not share, and you will continue to believe that you don't have a problem.
Yes, I appreciate those words again from both Dr. Greer and Dr. Pugh. I think often about what's happening in the science world as far as research and the requirements to conduct research in applications, let's say to institutions like NIH. And so a couple focuses that I've brought to the council I sit on at NIH is that, we, we require innovation. And the best and highest and best and most in-depth innovation you can have is to have diversity, to have inclusion. And if we're not seeing that, or if that's not being talked about as far as that should be included on applications, then it's not innovative. One of the other focuses that we've been discussing quite a bit at NIH is, the whole area of inclusivity on an NIH application. So an application says they're going to include 500 white participants, subjects, and to meet the inclusion criteria, we'll have 4 African Americans, 1 Hispanic, and usually no Native Americans. And that's supposed to meet the inclusion criteria. And so there is discussion now about that's just not okay anymore. That really is not inclusivity. And so the work and the studies that need to be done so that standards are developed that are appropriate for diverse populations. Yeah, there needs to be some changes. And so that I know is being worked on, and we are continuing, and we appreciate any support in sending that message that this is what it means to have inclusion.
100%, John. And one of the other things along with that too is we have to be very inclusive of community. One of the things that we started doing is we offer voluntary faculty appointments to community members that are community partners who are actually teaching our students that do not have degrees, but yet they are part of the educational process. Why should they be excluded? I mean, how many voluntary faculty appointments do we give to MDs that'll see one student every 3 years? It's prestigious for everybody out there. Share that prestige.
So another question from the audience is, for those of us able to impact younger aspiring physicians through pipeline programs, what opportunities do you see for promoting inclusive mindsets?
I think Carla said it best when she said, we can do this. There's no reason we can't do this. I'm the eternal optimist. So I'm going to say, Carla, I'm on your team. We can do this. And being an ex-football player, I can always stand over somebody and say, listen, if you don't do it, you're in trouble. No, I wouldn't do that. I'm a internist, not a surgeon. I couldn't fix them afterwards. But the idea is, yes, we can. And leadership offers us that opportunity to be able to do that. And having met now on these Zoom calls with John and Carla, Dr. Lowe and Dr. Pugh, is meeting leaders that are willing to do what leaders are supposed to do. It's not about you. It's about making it better. It's about giving opportunity to others that otherwise would not have had those opportunities.
Does anyone else want to
I
weigh in on that?
I think simple beginning. I think a simple beginning. Just take a look at yourself and your circle. Who are your colleagues? Who are your friends? Who are the students you support? Who are the students you feel most comfortable with? Reach out to one person a month that you've never reached out before, that you have that feeling when you look at them. All those, and you don't really know what the feeling means, but address that. One by one, it will totally make a difference. That one partnership enables that person to have a sense of entitlement and freedom and sense of belonging that is unmeasurable in terms of the ripple effect. It's so simple, and I think we're just so fearful of making a mistake on both sides. We're missing that human connection because everyone's fearful. Well, should I call you Black or African American? Well, the person who's angry about it is just not ready, but that doesn't mean it doesn't mean you should stop trying. Some people, they have justified anger, and others are ready. I've been angry a long time. Now I'm ready to do something different. Keep fighting to find that one person who's ready to partner. I think it's human connection.
Yeah, I agree with that. And again, connecting to your purpose, I would, wherever you find yourself, find your voice. In whatever situation you're in, find your voice and be able to give voice to whatever the situation is. And if there is non-inclusion, give voice to it. And it's easier in some situations than others. And recently I was asked to return to my high school where my twin brother and I were sent away from our tribal community because our families thought that we would have a better opportunity in a public school. So we went to and stayed with relatives in the area where my mother was from. And I shared with the students, I'm still alive and I went to this high school. And when I entered 9th grade, I was told by the high school counselors that since I shared, my goal was to go to college, and I was told because of who I am and where I was from, I could not, people from where I was from did not go to college. And that was not even to be considered as an opportunity. So now explore the opportunities. Is it different? Do you have opportunities? Explore them and grab them and go with them. And if I could, as an example and just as a role model, do what I was able to do, then look for those opportunities. And so we talk about that. And I think that's, again, giving voice and having a voice is very key to today's world.
Thank you very much, Dr. Lowe, Dr. Pugh, and Dr. Greer. And to all of our participants. There are many other questions submitted. Unfortunately, we're not able to get to them in the live session today. But thank you to everyone for your thoughtful questions and engagement in this session. Well, we've covered a lot of ground today. Much remains to be done. Before the Q&A, we had asked each of you to consider one thing you could do to advance progress toward inclusion, belonging, and equity. And now we'll look at the ideas that were shared. I think Jean has shared those. And I see reach out to connect to someone I don't know who's different from myself, to do it monthly. Own my own part of the problems. Set the bar higher. Expect more students from the start. Ask clients about their experiences with healthcare. Work to reduce barriers to enter into medical school for individuals from marginalized backgrounds. Really loved hearing Dr. Greer's sharing from you, underrepresented in medicine in Blues Medical School. Pose that question to myself as I'm organizing my work. Address and debrief microaggressions to turn them into learning experiences. Ask what others need. So these are really good ideas, and thank you to everyone for sharing them. Once again, we are grateful for all your thoughts and contributions. At this point, I will turn it over to Dr. Maurana for closing thoughts.
Thank you, Dr. Stawski. It's hard to end this. It's such a powerful, powerful presentation and conversation. Thank you so much to each of you for joining us today. And I would just, we're almost close to time. And so there's some information on the next 2 slides, but I would just like to end by saying that, we know that not everyone agrees on the path forward. We've talked a little bit about that. And so we hope that this encourages us to reach out to others for conversation, like Carla talked about in terms of making a partner, making a connection, and that we're able to work to bridge divides and find common ground, and that we work to lead with empathy and intellectual humility, which is something that we've talked about. And so we hope that the experiences of our panelists and the next steps that are shared today offer us both inspiration and food for thought on this very important journey. And so I would simply like to end by quoting Dr. Greer, that this is our world to make better. So thank you, everyone.